And yes, thank you, Warren. If anyone has a question, please feel free to put that in the chat. Oh, and I guess I'll have to share my screen. Stop that. I'll keep that going. Share my screen. Here we go. Let's do this one. Okay. So, this bigger. There we go. All right. So, we're going to talk about this. I'm going to talk a little bit about audit and feedback, what that is, why it's a useful tool to use, especially in the world of antimicrobial stewardship, and then we'll talk a bit specifically about what happened or has happened so far with this intervention, as it's not something that has finished, per se. So I just want to start with talking about antimicrobial stewardship in primary healthcare. So we know from data, and this is actually hot off the press, 3-year-old data from CARS, so the Canadian Antimicrobial Resistance Surveillance System. They have a report that they put out every year, so this just came out last week or 2 weeks ago, I think. But it's showing in red the usage of antimicrobials in the hospital sector, and in blue in the community sector. And so you can see that the vast majority of antibiotics are used in the community sector. So more than 90% in Canada of antibiotics are prescribed in the community sector. So if we want to talk about where we might get the most bang for our buck in terms of antimicrobial stewardship, clearly community is the place that we want to have at least one of our focuses on when we're working in this world. And if we think about the appropriateness of antimicrobial use, so there's all kinds of data out there. This was a recent paper from Canada, actually in Ontario. They had done a study where they looked at antibiotic prescribing in primary care and tried to parse out what those antibiotics are being prescribed for, to try and look at how appropriate that is. So for example, these tier 1, this bar here represents for different age groups. So I think the blue and the under 2 years, and then 2 to 18, and then basically adults and older people. And so if you look at this, that shows that about, 7% or so of all those antibiotics were ordered or were prescribed for these tier 1 indications. So these are things where an antibiotic is always required or would be appropriate for treating. But the piece that I want to talk about is these tier 2C and tier 3 antibiotics. And so what these are antibiotics that are rarely, or indications for which an antibiotic would rarely be needed or never. And so together, those make up 24% of the antibiotics that were prescribed. And so, things like maybe otitis media in adults, where you would rarely need an antibiotic, or a sinusitis or something like that. And then in this case, you'd think like viral respiratory tract infections, or asthma is often something that's given and really doesn't require antibiotics. So this actually is in line with other stuff too. So there's data from the States, older data, that showed about a 30% of antibiotics in outpatient settings are deemed unnecessary, so are prescribed for things that do not require antibiotics. So we're in line with data from elsewhere as well. So when you look at these together, it shows that if we're talking about antimicrobial stewardship, clearly we use a lot of antibiotics in primary healthcare, and there's certainly room to improve on the appropriateness of that antibiotic use in that sector. So back in 2016, when our antimicrobial stewardship program started here in Regina, this was one of the things that we took into consideration is, okay, we were kind of looking at what we can do inside the hospital, but we also decided we need to take a look at the primary healthcare setting, and we can't just ignore that. So Bob and Casey and I went tearing out of the hospital and did a bit of a road show, and connected with people in the community to try and better understand what the needs were for antimicrobial stewardship in the community, what kind of interventions would be most effective, and just trying to get a sense of how we could be most effective in doing antimicrobial stewardship in the community. So I want to start with some of that preliminary work just to lay the groundwork, just to kind of let people know that this isn't something that just happened overnight. This is something we've been working at for several years. So one of the first pieces is actually one of the papers that we published just, whatever this one was, a year ago, 2 years ago, And so you can scan the QR code there if you want. But this is some of that lead-up work. So one of the things we initially did was we had a student at the time, Christine Lee, who's now a pharmacist here in Regina, but she performed a survey in the first summer we were operating of community practitioners. So we had family physicians, we had community pharmacists respond to that, we had nurse practitioners, and we even went into the veterinary world. But basically the idea was to ask those folks, if we were to implement an antimicrobial stewardship program in the community in Saskatchewan, what would that look like to you? What would be most effective and most beneficial to have? And so the purpose of this paper here was to talk about the viral prescription pad, which is one of the things that we developed out of that. And that's something that's now available through Choosing Wisely Canada. It's been adopted by our X-Files here in Saskatchewan and Choosing Wisely Canada nationally, and it's part of their Antibiotics Wisely toolkit that they have available, so we're quite proud of that. But at that time, locally, it was just us trying to get out and get that information out there. So once we developed that, we partnered with some of our colleagues in primary healthcare and just essentially sort of hit the streets and knocked on doors and went to clinics and delivered viral prescription pads just to get that information out there, talked with them about antimicrobial stewardship, and just tried to really start to get the ball rolling on getting people involved and aware of the existence of this. And it wasn't always successful, so this is a dramatic reenactment of something that is still a bit of an inside joke between Casey and I, where we showed up at a clinic, and I don't know if they took us for drug reps or something, but they basically, the first question was, did you bring lunch for the doctors? And we didn't really have a response of no, so we're here to talk about antimicrobial stewardship. So anyway, not always a success of doing those cold calls, but we did make some connections at some point, and that helped to sort of pave the way, really identifying clinical champions and clinician champions, people who are out there who actually care about this and want to help implement it in their clinics or primary healthcare networks, whatever the case might be. So as all that was happening in the background, we were kind of looking at ways to identify data and actually get some numbers to go out and talk to people. And so we hit kind of the jackpot in the data analysis world. So we discovered that there were a handful of clinics in, at that time, the Regina-Capel Health region, which all operated off of the same EMR, a MedAccess EMR that was owned by Regina-Capel, which meant, as far as access to data, that helped eliminate a bunch of barriers in terms of creating data sharing agreements with a bunch of different individual clinics. And we could actually, they were all collecting data into one system, so we could collect and compare over time and among those clinics without having to sort of go through all the data sharing and those types of pieces. So we were able to quickly get access to a lot of relatively high quality electronic information. So with that, we decided, okay, we have a bunch of information. We know a lot about the prescribing habits of some of the different clinicians. So what can we do? And so we kind of thought, okay, well, let's maybe try and develop some sort of audit and feedback, something that eventually developed into what we call now a clinician report. But I just want to talk about audit and feedback for a moment, just in case there's anyone on the talk here who's not familiar with that. So this is essentially something that has been used extensively to modify clinician behavior. So you audit a behavior, so the number of prescriptions or the number of tests ordered, and you feed that information back to clinicians with the goal of kind of changing that behavior. So if you're trying to say, you know, in this case, are we prescribing too many antibiotics? We can show clinicians where they fall on, you know, are you using more antibiotics than your colleagues, and things like that. And then you can use that to drive behavior change. So, and you can see here, this is just a graph showing the number of articles on PubMed that have been indexed with audit and feedback as one of the keywords. And you can see that, you know, even in 2021 there, it was over 300, so more than an article a day is being published with audit and feedback. So it's something that has grown really quickly in the healthcare world as an effective tool for behavior change. And so that's really what I like about audit and feedback, is it's both a tool and an incentive for behavior change, as long as you're using it effectively. And that is a key piece of that. But if you think about behavior change, and this is just one model that I like to use, this Combe-B model. So whatever your behavior is, that behavior is a function of a person's capability, opportunity, and motivation to perform that behavior. So if we want physicians to increase the number of antimicrobial prescriptions with indications, are they capable of doing that? Well, sure they are. They have to put that into the EMR. Do they have the opportunity? Of course they do. When they're writing out the prescription, they have the opportunity right there to put it into the EMR. Are they motivated to do it? And that's often the key factor is, well, they have no reason to do it if they're not already doing it unless you provide them with some motivation to do that. And so that's where audit and feedback can work. If we give people the evidence about why it's important to include antibiotic prescription indications with antibiotic prescriptions, and then we can show them how they compare to their colleagues or how they compare over time. Are you putting your indications down compared to, you know, other colleagues in your same practice or whatever? That can be a big motivating factor for people who don't want to be at the bottom of that list. I don't want to be the one that only has 20% of my antibiotics with an indication if all my colleagues are up at 80, 90% of their antibiotics having indications. So audit feedback can be a really powerful tool for helping motivate and get that behavior change that you're looking for. And there's a lot of research that's gone into how audit and feedback works, and it's still a growing field. This is one of my favorite references, and it's something that we try to include when we're designing and developing implementation projects. And so this was a Cochrane review that looked at the effect on professional practice of in healthcare from audit and feedback. And so they found a range of, I think, from 4 to 16% change when you do audit and feedback, and they came up with some of these things that were shared between studies that had a positive effect from audit and feedback. So it's most effective when you have health professionals that are not performing well to start out with. If you have the person responsible for the audit and feedback is a supervisor or colleague, so getting that champion to help with the feedback. If it's provided more than once, so you're not just a one and done kind of thing, but coming back over time to continue that feedback. If you give it both verbally and in writing, so we're not just going to talk to them, and we're also not just going to deliver it, you know, just in writing and not have anything to say about it. So having that combination gives you a better effect. And if you include clear targets and an action plan, so what do we want you to do? So what is the target behavior, and how are we going to get there? So all of those things, if you can manage to get all of that into your audit and feedback initiative, that will help set you up for success or to have the best success that you can with the behavior change you're going for. So we started collecting data from that EMR, and we built, as I said, a clinician report. So this is just an example of some of the stuff that's in there. So for example, we would have a slider bar at the top that would let them choose the years of data that they want to look at. And then we could show them things like the number of antibiotic prescriptions per 100 patient visits, broken down by prescribers. So each one of these colored bars represents a different prescriber in that EMR. And you can see that some people are relatively high prescribers and some people are much lower. We could highlight just the top 10 or top 20, whatever you want. And then this shows kind of the overall average number of prescriptions for the whole group on an ongoing basis. So give them some of that big picture data to see where they fall within the group and what that looks like over time for everyone as a group. We could also highlight things like individual antibiotics. So here are the top 4 antibiotics in our Regina community, these clinics that we're in and around the Regina community. And you can see how those change over time. And then this one down here allowed us to break down by prescriber what proportion of their antibiotic prescriptions are attributed to these top 4 antibiotics, and then the gray bar is everything else that they prescribe. And so this is interesting too, because prescribers could look at this and you'd have some prescribers like this person in here, where it's mostly green, which I think is azithromycin. So you can see that the majority of their prescriptions are actually attributed to azithromycin, whereas maybe someone else, they're actually for amoxicillin. Or some people have a larger group of other things and don't prescribe as much of those. So it allows people to look and see what the variation in practice is and start to think about, do I need to be prescribing as much azithromycin as I do, or is amoxicillin a more appropriate antibiotic for some of the things that I'm prescribing for? And therein actually lies the rub for us. So one of the problems we came up against was, as we presented this data to different clinics and asked the clinicians, you know, what do you think, what can we do with this, what's going to be useful, it came up time and again that there's only so much you can do without knowing why we are prescribing these antibiotics. So what are we what are these things being prescribed for? And you can see that out of 40,000 prescriptions that we had, only 9,000 had an indication listed in the EMR. So that's that big gray part of the donut there. 78% of our prescriptions didn't have an indication, which means we have no idea why those antibiotics were prescribed. And you can see that over time, that really didn't change a whole lot, where we had usually less than 30% of our antibiotics had an indication every single month. So this was something we needed to work on. And it's something that was not the same across the group. So here is showing, again, each individual provider, but showing their percentage of prescriptions. And we gave them this target of like 80%. If you give us at least 80% of your prescriptions with indications, we can start to do something useful with that data. So you can see that there were some people who were already performing well and had 80, 90, 100% of their prescriptions having indications. And you can see that there were a large majority of people who had lots of room for improvement. And in fact, half of the prescribers had less than 20% of their prescriptions with an indication, which means their data are almost useless when it comes to trying to determine appropriateness, because we really don't know what they're prescribing for. And so just to highlight, if we know what is being prescribed but not why, it makes it difficult to measure that appropriateness. So this is an example. So for one of the prescribers from there, who had more than 80% of the prescriptions with indication, and as did prescriber B. And when we start to break down, based on this pie chart here, what they're prescribing, so this blue chunk here, the light blue chunk, is upper respiratory tract infections. 25% of this prescriber's prescriptions were for upper respiratory tract infections, compared to 8% for prescriber B. And if you add in lower respiratory tract, which is this darker green here, this is another, I think, 30% or so for this prescriber. So more than half of this person's prescriptions were for upper and lower respiratory tract infections in the community, compared to about 12% for this person. So that actually starts to give us things we can work on. So we can say, there's an appropriateness piece here. Is it appropriate that 50% of your prescriptions would be for upper and lower respiratory tract infections, especially considering someone else is only prescribing about 12%. So are there differences in your patient population, or is this just a difference in practice and appropriateness of practice? So that brings us to why are indications important. And I've just got a list here that I pulled from another presentation, which I have a whole presentation that talks about the importance of indications, but I just want to run through this quickly. Why should we include them? In long-term care and acute care facilities, the data shows that it provides clear information to the rest of the healthcare team as to why the antimicrobial therapy was initiated. It reduces time searching through patient charts and records to determine the purpose for the antimicrobial treatment. It reduces the length of therapy and length of stay for patients on antimicrobial drugs. It reduces unnecessary antimicrobial use and overall prescribing, and provides increased patient safety by having all relevant information clearly documented in their chart. In primary health care, it's much the same, just in a different setting. So you've got clear information so that, for example, community pharmacists can better understand why this antimicrobial therapy was initiated. It will reduce the time of trying to connect. So when a community pharmacist has to try and track down a doctor to understand why this was prescribed, and then reduces time for doctors having to, find time to talk to the community pharmacist. Reducing that length of therapy, so again, just things where it's like having someone to be able to double check and say, okay, for this indication, do we have the right dose? Do we have the right length of therapy? Can we reduce that? Those kinds of things. Or just simply reducing unnecessary antimicrobial use overall by having a second look at that. And then, of course, the increased patient safety that comes from that. So it's all very much the same. Again, I've got a whole other talk that we can dig into the data and the references for that. But suffice it to say, there's good reason. And in fact, in a lot of places around the world, indications for antimicrobial prescriptions are becoming a standard or a policy in different places, that this is required for your prescription to be considered valid. So the task for us was to pump up those rookie numbers and get our indications up to a level that is going to make our data more useful. So this is a paper that we just published on this work, and you can scan the QR code there if you want to check that out. I'll give you 3 seconds, 2, 1, moving on. So the lead up to this, again, we didn't just jump into this and start telling them, do better, here it is. We wanted to better understand the context around why we weren't seeing indications in those EMRs, so that we could try and deal with those problems first, so that the only barrier was just the motivational aspect. So the first thing, we talked to those groups when we were going out and presenting this to them and say, okay, why is it that we have so many physicians with so few indications being recorded? One of the things we found out through that was that the physician's workflow, or the prescriber's workflow, did not match the workflow in the EMR. So this is just an example screenshot of MedAccess, and it was something, I don't recall the exact reasoning, but something to the effect of by the time they get to putting the diagnosis, they've already gone through the prescription aspect, and they didn't want to have to go back to click in and figure out where to put in their indication in the prescription. So to remedy that, we worked with Caitlin Hansen, who's one of our friends and colleagues over in primary healthcare, and or was at the time, I think she's digital health now. Anyways, she helped to develop and distribute this standard work. So basically, we created a document that would help inform physicians and prescribers how to properly add an indication to the prescription. So what is the process you need to go through so that it gets into the right box, in the right place in the EMR, and how you can make that work in your workflow so that it's happening at the right time so they don't have to go back and click and change things. So there's a bit of an educational piece here about just getting people to use the EMR properly so that they're putting in the right information in the right spots. The next piece that we found was that even if they had, at that time, if they had put an indication in, it wasn't being pulled into the electronic prescription when that got sent, emailed, faxed, whatever, to the pharmacy, which means the rest of the care team, like the community pharmacists, wouldn't actually see those indications anyways. And that was kind of the crux of this, was this patient safety aspect of if you include that information so everyone knows, it will be there, and it wasn't going to be there. So our solution to that was to reach out to the vendor and have their computer nerds go in and make whatever changes in the system that they needed to do in order to allow that indication to be included on the electronic prescription. And full disclosure, I have no idea if that's what the working conditions are like at TELUS Health there in their MedAccess, but that's what pops up in my mind. So, okay, so then we actually got to the intervention piece. So we kind of filled out the background, and we're like, okay, I think we've eliminated all the barriers to you guys actually doing this, and the only thing that remains is getting people to actually just go and do it. So we, with in mind, what we wanted to do was, go out, and we knew that we had health professionals who were not performing well, so we knew we had lots of people with lots of room to improve. We were trying to find, and we were meeting with champions so that we could have people who could help invite us in to their meetings and promote within the clinic the work that we wanted to do. We were going to go back multiple times, have multiple meetings. We were going to do this face-to-face, and as well as provide the report itself in writing. And then we had that clear, like 80% goal, and then develop an action plan with the clinicians to say, how are we going to get there? And then, of course, this was right around February, March of 2020, and so COVID hit, and we had to be nimble and make adjustments. So things kind of got shut down, as everyone is aware. And so we said, okay, well, then let's just try Zoom meetings and things like that. Well, people were so busy in the community and things were changing so fast that that just didn't really pan out. And so this was me, the little guy in that burning house thing going, this is fine, we'll figure it out, we'll get this done. So be nimble, and we just decided, you know what, let's just do this by email. That will be the easiest thing to do. At least we can get the information out there, and we'll just see what happens with a more limited something that we knew might not be as effective as if we had gone out in person, but at least we could start doing something and start seeing how this could work. So Shivani, one of our analysts, has been, since the start of this, putting together monthly data that we send out in an email to these clinics for them to forward out to their prescribers. And what it has is, again, each prescriber has a code, so they can click on their code, and it will bring up their data from the last month all the way back to when we started collecting, which was, I think, 2019. And so you can see this is, for each month, what the percentage of antimicrobial prescriptions has an indication. And then we even break that down by showing them the number of prescriptions, and then the blue bar is the number of indications. So they can see if that's based on 2 prescriptions or if that's based on 20 prescriptions for that last month. And so some prescribers have done really well and have really gotten up to and maintained that sort of over 80% of their prescriptions with indications. Others still struggle and probably just aren't looking at the data. But that's where, you know, our next barrier is, okay, how do we start to reach out to these people who have been unsuccessful at increasing their number of indications? So the question is, did this work overall? So we've been doing this for, I guess, a year now that we've been sending this stuff out. 2 years. It's 2022, so 2 years that we've been sending this data out. For when we published this stuff, so we just had data up till the end of last summer. And so this is a control chart which kind of shows, again, for each month, what is the percentage of prescriptions with indications. And so you can see that it varies from month to month, and we had it go higher some months and lower some months. But you can see, on average, this middle line here is the 21.4%. So on average, before the intervention, we had about 21.4% of prescriptions with an indication. When you look at after the intervention started, so in March 2020, we started sending out this data to them, and we started to see this increase and this change in the average. So by the end, or by August of 2021, when we had looked at the data, we were up to, on average, about 37.8% of antimicrobial prescriptions having an indication amongst the whole group. So that was good. I mean, we're nowhere near 80%, but we've certainly seen an increase, which means there are more prescriptions with an indication, which means that information is in those patient records and can hopefully be doing good in some of the ways I talked about earlier. And then kind of the big question for you, when you look at that big picture data, the question is like, but did it really work? Like, how many people are doing this? And like anything, when you're talking about an average, there is a range. So what this is a really neat graph that Warren came up with, another one of our analysts. And so Warren was able to show here, each of these blue dots represents the pre-intervention value for an individual physician, so their average number of prescriptions with indications pre-intervention. And I think we eliminated everyone with less than 5 or 10 prescriptions just to keep out some of the wonky data here. And so then I'm going to click the thing, and so now you see the red is the post data. So the majority of the physicians, in this graph at least anyways, we saw an increase. In some there was quite a nice big increase, some it was slightly smaller in terms of seeing a change in the number of indications with prescriptions. And then of course there are individuals who went the other way. For some reason they had fewer prescriptions with indications after the intervention started, and that's just some of the way that this data goes. But I think, you know, overall you can see that their physicians are trying and making a change, and they're not all hitting that 80%, but we are seeing positive indications of change, and it's just a matter of now finding ways to really drive that home and try and affect better change amongst some of the people who are struggling. So, next steps. Reach back into our British ancestry and keep calm and carry on and just try to keep, you know, working through the challenges of the pandemic. How are we going to get this done and work within the constraints that COVID is presenting to us? I feel like a part of me just wants to get a little bit more assertive, that's a better term, assertive, where we're just going to go out and be like, okay, here's the data, people have started doing this, can the rest of you please just do it, right? And so we have to do that in as cordial a manner as possible, trying to build relationships. But I think the bottom line here is that it can work and it can be effective, and we just need people to get on board. And then the last piece is we're going to have to stock up on turd polish, because one of the big pieces of this is that we are asking people to put an indication into an open text field. And we automatically know that you know, acute exacerbation of chronic COPD, right, is going to be written in 100 different ways by 100 different physicians. So there's already going to be a lot of data cleaning that's going to have to go on, and we're going to have to see how we can polish that up to make it something useful. And of course, we've tried connecting with the vendor as well to say, like, is there a way we can standardize this with like an ICD code list or something like that, so we can already start standardizing that data. And that's a much bigger conversation that we have to have with them. But certainly there are going to be, even once we get the data, there are going to be troubles in terms of cleaning and stuff like that. But these are all sort of baby steps along the way to creating this better bettering our ability to do antimicrobial stewardship with these community clinics. So I will stop there, and I will thank you all. Where do I stop sharing? There we go. And I will stop recording, and if there are any questions, I would be happy to answer those.